I'm going to speak. I have actually two presentations to give back to back, and so I'm going to go rather fast in an effort to try to get us close to being on time. This first presentation is about the mitral clip, and just to put this in perspective, there are about 250,000 of patients with significant mitral regurgitation diagnosed in the United States on an annual basis. Medical management is relatively effective for these patients, so these patients sort of linger until they get into extremis, and then we wonder about more definitive treatment. Surgical repair and replacement is the standard of care, but only about 20% of patients actually receive this surgery. When you look at the sort of total cohort of mitral valve regurgitation patients, there are over 4 million patients in the U.S. But when you just look at the bottom of this pyramid, you see that the annual mitral valve surgery is only about 20,000 patients. So a significant number of patients that are either treated medically, whether that's adequate or not remains to be decided. The classification of mitral valve regurgitation can be of two types, and simply stated, it's either the ventricle enlarges and the valve doesn't coapt, or there's something structurally wrong with the valve. And so the blood leaks during systole into the left atrium as the ventricle contracts. These are representative echo images of primary and secondary mitral valve insufficiency. And you can see that it can run the gamut of being either the posterior or anterior leaflet. The leaflets can be flail, or it can be a bileaflet abnormality. And so targets as far as mitral valve repair are the leaflets, the annulus, the chordae, and the left ventricle itself. The edge-to-edge or mitral clip concept, this was derived from a surgeon who actually sewed the two mitral leaflets together, creating a dual opening for the mitral valve. And this significantly decreased the amount of mitral regurgitation and was the impetus for developing the mitral clip. And so schematically, you can see what's done here. The mitral clip is advanced through the left atrium. The edges of the leaflets are captured with the clip, and as the clip is released, you create this dual chamber or dual valve configuration. This is a representation of sort of the equipment, or one of the pieces of equipment that you need to have. This is not for every hospital. Just getting started in putting this equipment in your hospital is probably an endeavor that costs you about $60,000, apart from the price of the clips that have to be purchased. The indications for mitral valve operation were looked at or published in 2008, and then a revision was done in 2014. This is readily available on the internet, so I'd encourage you to look at this. But one of the things that's happened is that the indication for clip, or this transcatheter therapy, had moved up as far as the recommendations were concerned between 2008 and 2014. And this is sort of based on the data that was published in the New England Journal of the Everest series of trials. The Everest 1 trial proved that this was both efficacious and safe. Everest 2 looked at a large number of patients. These were patients that had severe mitral regurgitation, either class 3 or class 4. And sort of the inclusion and exclusion criteria, again, is readily available on the internet. But you can see that of note, the exclusion criteria include recent myocardial infarction and need for other cardiac surgery. So this was a sort of select group of patients with mitral insufficiency that underwent mitral valve repair. Some of the baseline characteristics, again, are relatively available on the internet, but suffice it to say that these patient groups were very closely similar before they were randomized to the trial. And when we look at the patients that got both surgery or got the percutaneous valve, we can see that just one of the general things to look at is that the patients that received the percutaneous clip were a little bit older population than the patients that received the surgical valve. Yet, when we look at the results, we can see that there was a tendency that the surgery was favored over the clip, but for revascularization, patients that had lower EFs or that were older patients tend to do better with the mitral clip as opposed to mitral valve surgery. And if we look at, again, something interesting, the recurrence, or how many patients had mitral regurgitation after the procedure, you can see that going into the procedure, the groups were very similar, and after the procedure, there was clearly a decrease in the control group or in the surgical group over the device group. But yet, in late follow-up, even out to 5 years, we can see that these groups are very similar. In the high-risk group, there was a high-risk category or cohort of patients that were looked at. And of note in particular in that high-risk group, those patients that would be considered high risk or at exorbitant risk for surgery did better with the mitral clip as opposed to doing the mitral surgical repair. Now, even again looking at subgroup analysis, and we look at the plots here, we can see that certainly the patients that had higher age and had lower EFs were favored by having the mitral clip. The majority of patients had degenerative mitral regurgitation. Some were actually low risk for surgery. The mitral clip was safer than surgery in some patients. There was transfusion requirement that sort of skewed some of the data. And long-term freedom from severe MR was good in both groups. So the severe MR, the MR that led to patients being candidates for heart transplant, the MR that led to patients being non-functional, did not occur in either one of the groups. And based on this, the FDA gave provisional approval for this device in patients that had degenerative mitral regurgitation. But understandably, the operators that were in these trials remained cautious in using this technology, and so even though it's available on a commercial basis in the U.S., it hasn't run amok. And the results have been very good because the operators that are doing this procedure are using their due diligence to make sure that the patient population that's selected is the appropriate patient population. And as I alluded to earlier, at 5 years, the severity of the mitral regurgitation has been reduced. Functional class has remained better than what it was. And beyond 6 months, the rate of mitral valve surgery was low in the clip group. So one of the concerns was that there would be attrition of these patients. Once they had the clip, it worked for a short period of time, and they would progress to need mitral valve surgery. That has not been the case. Other trials apart from the Everest trial, the Realism trial, which was another continued access trial, and in the commercial trials, both in the U.S. and in Europe, you can see the statistics here. So the results have been, so far to date, durable, with data out to at least 5 years. This is the results from just the European registry data, again, very similar to what we've seen in the U.S. So this led to what we're calling the COAP trial. This is an ongoing trial in the U.S. now, randomizing patients on a one-to-one basis, looking at safety and effectiveness of the clip versus surgery. And in this trial, we can see that these are actually sicker cohort of patients than what we had seen in the Everest trial. There are 430 patients going to be enrolled at 85 centers in the U.S. And I can tell you that as far as the inclusion and exclusion criteria, I go through these very quickly because there are a lot of inclusion and exclusion criteria. In my institution, we have research people that come and screen these patients to actually decide or to help us determine whether the patient fits the protocol or not. Because the average patient that gets referred to us in the clinic that we screen, we think we've done a good job at screening. When they go through the entire list of the inclusion and exclusion criteria, the majority of those patients are not randomized to this trial. They don't fit. And then the primary endpoints, again, will be effectiveness and safety. Secondary endpoints, again, similar to what we've seen in the previous trials. And of course, all-cause death and mortality. This is a timeline that just shows how this technology has evolved over the years, and we're still in that sort of continuum of what's next. The mitral clip is certainly an advantage or something that we hadn't had in the past, but in the future there are a number of prototype devices to actually replace the mitral valve. This tends to be more challenging than what we see in the aortic position, but certainly something that operators are continuing to show some interest in. So 1/4 of the patients with heart disease in the U.S. have mitral regurgitation. Mitral valve repair is recommended over replacement for the most part. The Class 1A level of evidence is C. Transcatheter mitral valve repair and replacement is much more complicated than TAVR. So this is a lot more complicated than replacing the aortic valve percutaneously. The trials that I talked to you about very, very briefly showed that this was effective for degenerative mitral regurgitation and has led us to the trial that's ongoing right now, the COAP trial. And ongoing research will determine which patient populations are best treated or best suitable for these technologies and what's the best technology to actually apply to in the individual patients. Thank you very much.